So the votes are in, and Dr. Richards is still giving grand rounds presentation this morning. That's what we've elected.
Thank you.
So last month, Dr. Richards gave some back-to-back talks about bladder cancer. And so rather than redoing his expertise and passion for bladder cancer and taking care of our patients, it's kind of an apropos topic to talk a little bit about health policy and business of medicine this morning. Specific to this talk, Dr. Richards has an interest and leadership positions at the national level within health policy. He serves as the American Urological Association representative to the American Medical Association Relative Value Scale Update Committee, which I assume we're going to be hearing a little bit about that during your presentation. But it's a big deal because the AMA's RUC, which is the committee, advises the CMS about how to set relative value units for providers. And in many healthcare systems, RVUs are what drive compensation and provider reimbursement. So with that being said, thank you, Kyle, for your presentation in advance.
Thanks, Dan. Can you guys hear me back there? Dr. Graulich, we good? And thanks for coming. Thank you all for being here. And we're really going to sort of spend the next 40 minutes kind of taking a bit, maybe a 50,000-foot view of the issue, and not so much sort of the nuts and bolts of coding and reimbursements. I think we can do that, maybe another time, and maybe in a rec or something. But this is more of a big picture view, and this is our outline for today. And I wanted to throw in some pictures of my daughters. So there's Sophia and Sydney, summer vacation in Canada, in Quebec City. And just like when you go on vacation and you have an itinerary, you have a map, you know where you're going. This is sort of our map for today. So we'll be talking about the role of urologists in health policy and advocacy. You might be saying, well, what role do I have? What can I do? And so the first part, we'll give you some ideas, and maybe you can give me some ideas, because I'm still sort of trying to figure out how best that we can get our young urologists engaged in health policy and advocacy. Then the middle section, we're going to talk about how qualified healthcare providers get paid. So not just MDs, but DOs, nurse practitioners, PAs. How do we all get paid? That's sort of, I think, understanding how the process works can help us to better make decisions. And then the last section, sorry, Dee's coming to the podium here. Oh, we got to share the slides. There we go. The last section will be, what the RUC. So what is the RUC? Dr. Williams alluded to it already, but we'll get into some of the weeds there and try to define some of the terms. All right, so I just leave the slide up there. So we all voted, most of us, or hopefully all of us, but Dane County, it was about 88% of registered voters voted in this last presidential election. But this was just prior to the 2016 election. The number of, the percentage of physicians that voted was right around 50%. So why do you guys think so few doctors voted back then? Time. Someone said time, right? Yeah, Zoe. So yeah, that's a primary reason. There's not enough time, right? We're pretty busy. You have a Tuesday in November, you've got to go to the polls. So there's not enough time in our busy days to vote, because we're pulled in so many different directions. So this was a story from 2016. Fast forward, this was a really nice report out of JAMA, where the U.S. Census Bureau actually does a survey in the weeks following presidential elections and midterm elections. And they survey 60,000 households nationwide with pretty good response rates, 80 to 90% response rate. And what you can see is the probability of voting in the dark color are the physicians, and then the lighter color are the general population. So going back 20 years, the general population has outpaced physician voting. In 2016, though, physicians actually started to vote at higher rates than the general population. And then in 2020, it increased even more so. And these rates of physician voting are even higher in states that have laws that allow early voting and mail-in absentee voting. So this is our most sort of basic civic duty, is to vote. And I do have to report that I think physicians are doing a better job of getting out and voting, as this data from JAMA shows. So getting into sort of the current state, though, of health policy and advocacy, I think overall, and one of the reasons for doing a talk like this, and I've given some of these talks at the section meetings and on the national level, is that what we're hearing from our membership is that urologists overall are lacking in health policy advocacy knowledge. There's definitely a lack of participation locally, regionally, and nationally. And this is really, we all should pay close attention, because this is a really critical period for health policy advocacy. There's this changing landscape of physician reimbursements that's sort of swirling around. We have workforce challenges, as many of us in this room know, et cetera. So this is sort of the current state. And one of the, this is Candace Granberg, who's done a great job within our section, along with Kevin Koo, of sort of getting out and sort of grassroots, I sort of call it peer pressure, but don't underestimate the power of that. And participating in the AUA PAC and other initiatives can help move the needle forward. So I would encourage you all to try to get involved. Has anybody read this book, Man's Fourth Best Hospital? Okay, good. It's a good book. It's the sequel to The House of God. More people are probably familiar with Samuel Shem's House of God. It's a satire on healthcare. And this was sort of a more of a modern spin on the healthcare system, play on sort of the U.S. News and World Report's ranking system with the fourth best hospital. And although it's a satire, there's a lot of sort of truths within. And the doctors that are in the story, it's a fictional story, but it's a satire, are setting up a new clinic, and they are trying to navigate the process within a large healthcare system of setting up a new clinic, working with the electronic health record, getting the EHR to work for you. And it's a really interesting read. But one of the take homes for me was sort of the truth that came out is that there's this Roy's, the primary character, Roy, his wife is a psychologist. And she's trying to get this group of doctors and providers and nurses to work together. And to do so, I think this analogy works well for health policy, because we all have to work together to sort of move the needle from a policy advocacy standpoint. And it's called the relational model. And what they suggest is that the quality of one's relationships are what's really important. Because if you look at high quality relationships, and you can all think back to some of the relationships you have with friends, family, coworkers, they leave you feeling with 5 good things. So one is the increased sense of energy that you get from that relationship. It should increase your sense of self-worth. It should increase your sense of knowledge and increase your sense of power. And then you want more connections when you have these high quality relationships. So the self model is the opposite of that. That's sort of where you put yourself at the center of the universe, and it's more exclusive. Whereas the relational model is the relationship is at the center, and it becomes more inclusive. And then you build this mutual empathy. Whereas sort of an example is, when you yawn and then I yawn, that's the empathy that you're building from within. So we must do it together. It's really the we versus the I mentality. And I think that's how we can reach the next generation, is that we need more of these high quality relationships. We need more engagement. And we need to show all of you in this room and beyond the value of this work, so that we can stimulate interest and retain some of the brightest minds. We need to make this type of health policy advocacy work easy and efficient, so you can integrate it into your work-life schedule. And then I'm really happy to see a lot of our young learners and young urologists in the room, because that's I think how we can reach the next group of people. So we need to some ideas to sort of increase policy advocacy are potentially making it mandatory part of residency education. We're doing this grand rounds. after I gave a talk at the North Central section, the Cleveland Clinic asked me to come to their group and give them a talk on this topic. So I think annual presentations around the country are a good thing. State societies still remain critical. And then, if you have any ideas, we'll have time for questions at the end, or stop me in the hallway. Please let me know. So just some concluding thoughts that I have on this first sort of section on policy advocacy. I think urologists have an obligatory role in policy and advocacy, just like us being leaders. When we walk into the clinic or into the operating room, we may not have signed up to be in a leadership position, but physicians are leaders by nature. And I think policy advocacy is something we're also obliged to be a part of. You can volunteer at local committees or committees locally, regionally, or nationally. We're always looking for people to volunteer their time. You can support the AUA PAC. You can join AMA. American Medical Association is critical in not supporting just urology, but all of medicine. And then another good opportunity to get involved is the AUA has a summit every year where you can actually go to Capitol Hill and visit with your Congress people. All right, so step 2, or part 2 of our outline: how do qualified healthcare providers get paid? Sydney is doing a lot of chores, so that's how she gets paid, by doing a lot of chores at home. So she's carrying the buckets of water so that we can, drink some fresh water. And but no, how do we all get paid? So we're going to go through some definitions, and like I said, we're going to take more of a 50,000-foot view and not more of a nuts and bolts approach here today. But RVU, and there's a lot of acronyms and abbreviations, so I'm going to try to spell it out for people that are new to this. Relative value unit is really the currency of medicine. That's how I'll show you in a little bit how an RVU gets converted to an actual dollar figure. ICD is International Classification of Disease. That's also important to know what those are. ICD codes. Current procedural terminology. That's CPT. I brought my CPT book here, so if anyone wants to take a look at it. In fact, I may be giving it to one person if they can answer a trivia question coming up, so pay close attention. There's about, I think, 8,000 or so codes in here, but there's a lot of good stuff. So if you've never paged through one of these, it's actually worth a look, at least once. So every service that's provided, inpatient, outpatient, in the emergency room, gets an ICD code, a diagnosis code, and a CPT code. Now we have coders in our health system that do a lot of this for us behind the scenes, but when you're in clinic, you're entering your own codes yourself. So you need to sort of understand what codes mean and what you should enter. And then every CPT code is associated with an RVU. So there's an RVU with every code in this book has an RVU. And you can Google a lot of those if you're not sure, if you're kind of curious. I'll show you what some of the common RVUs are for urology codes. We'll get there in a little bit, but we'll start with ICD. I'm just at one slide on ICD. You could have a whole talk on ICD, but we're on ICD 10 right now. And what ICD has been around for a long time, and it really defines the entire universe of diseases, disorders, injuries, other health-related conditions. The main difference from 9 to 10 is it got very granular. This is just a screenshot showing, one that our residents have to deal with a lot, foreign bodies, right? So it gets down to, there's different codes for where it's located in the urethra, the bladder, and the uterus. So it's very granular level. There's 10 different codes for bladder cancer based on the location. So, it's a little bit more granular, which I don't want to get too much into that, but that's ICD 10. CPT is how we code the service that's provided. So it could be, and it's not just for procedures, it's also for evaluation and management codes, or E&M codes. Those are all CPT codes as well. Telehealth has CPT codes associated with them, and it's used to report the services for payment by a third-party payer. The largest payer in the United States is Medicare. So the RVU Update Committee works very closely with Medicare, and then a lot of the other private insurance companies sort of fall in line with what Medicare does. And this process with CPT is thoroughly regulated. There's a CPT editorial panel. The chair of that is Barbara Levy. And there are, the CPT editorial panel meets 3 times a year around the country, and they look at new and emerging technologies. The newest one for urology to get a CPT code is aquablation. So there will be a CPT code for that coming up probably next year. The CPT editorial panel has 11 appointed physician members and then 6 additional reps, including CMS. And then there is an advisory committee that advises the panel. There's 300 advisors and experts. AUA has a committee that participates in the process. If there's any AUA specific issues, the CPT panel for AUA will present those. For example, there are some new prostate biopsy codes that are coming down the pike that are being developed by the CPT team. And they can also suggest any sort of CPT revisions. If there's a code that needs to be deleted or removed for historical reasons, that goes through CPT committee. These are the AUA CPT reps, Jonathan Rubenstein, who's at Chesapeake Urology, and then Jay Matola, who's in New York, are the CPT team. And the RUC team works very closely with the CPT team. All right, so next up is RVU, relative value unit. So history lesson here. We're going to get into some of the politics that have sort of shaped the current system. So prior to 1992, we were paid based on the UCR system, which stands for usual, customary, and reasonable. That's how we were paid. And you might say, well, what is that? That seems kind of odd. How does that work? Well, it was very confusing because if you were in New Mexico, you might get paid one way, but if you were in New York City, you would get paid, and you did the same service, you might, what was usual, customary, and reasonable in New York versus New Mexico could have been totally different. So it really wasn't fair. It really was not equitable, and it led to really some issues with payment. So it was pretty clear that there needed to be somewhat of a frame shift as expenditures for healthcare in the U.S. Were rising. So for the we have to ask one of the residents this because I know Dr. Nakata knows the answer to this. But let's see, any of the residents know who this is? Okay, thank you. All right, just making sure. Okay, so this is Ronald Reagan, and Ronald Reagan, that was an easy one. It gets harder. Okay, you don't get the CPT book for Ronald Reagan. Okay, it's gonna get harder. Okay, so Ronald Reagan in the 80s did a lot of great things, and but one of the things he did was he identified that the current situation of payment for physician services was not tenable, as the costs of healthcare really were skyrocketing. And he said, we got to do something about this. We can't continue on this current pathway. The GDP is getting overwhelmed with healthcare expenditures. So he worked with some health economists at Harvard to try to come up with some payment reform that could work for the United States. So he worked with this gentleman at Harvard. So this is what will get you the CPT book, if you know who this is. Emmy, I know you. No? Nobody? Anybody? All right, that's fine. I didn't think anybody would know. That's okay. It's William Tsao. He's a health economist at Harvard. And in 1987, so he started working on this project right in the mid 80s. And he developed what he coined the resource-based relative value scale, or RVS. which we've sort of shortened to RVU. But essentially, if you see RV, RVS, and RVU, it means pretty much the same thing. Came up with this alternative payment system. And Reagan, I think, was very pleased. It had 4 objectives. The first was to develop a relative value scale that was based on resource costs for procedures within 18 or so medical surgical specialties. Urology was one of the original 18, so they were involved back in the 80s. But it was a frame shift because it wasn't based on what was usual and customary. It was based on the actual cost. And the second objective was to construct this relative value scale for procedures across the specialties, but then also subject them to review by physician panels. So there, you might say, well, he's a health economist. What does he know about health, about seeing patients? So he actually got physician panels from all the specialty societies to provide insight. They were also subjected to point 3, stakeholder review. So it wasn't just physicians, it was also CMS, insurance companies, other hospital administrators, other key stakeholders were also reviewing these. And then they wanted to, the fourth objective was to design a method, so to come up with a methodology and a process for reviewing RVUs. And that's kind of where the RUC was born out of, the RVU Update Committee, the fourth objective. So what are then, the other sort of theory behind this is, well, what sort of matters? What are the resource inputs that you want to put in to some sort of a health economy equation to sort of calculate the cost? So these were sort of the 4 main things that they felt was important. The first was time, right? Our time is valuable. So how much time does it take to do the actual service or the procedure? And we're talking skin to skin, or scope in to scope out for our endourologists. But also there's time before that on the same day where you're doing your, updating your H&P, you're doing your consents, you're marking the patients. That's time as well. That needs to be accounted for. And there's also time afterwards. You're dictating your op notes, you're writing prescriptions, you're doing your discharge paperwork. That's also needs to be accounted for. So that's number 2. That's the pre and the post-service time. The third thing they that felt was important was intensity per unit time. So how intense was that procedure? Was it one where you're, shockwave lithotripsy came to mind, but I don't know if I should go there. But where you're sitting there, it's not that intense. You're shocking a stone, you're drinking a Coke, these types of things. Or you're intubating somebody, right? That's a pretty intense procedure where you're trying to get that tube in the trachea. So they wanted to factor in some sort of intensity measure. And then there's also the cost of practicing, including malpractice, was important. So those are the 4 sort of main inputs to physician services that William Sow felt was important, along with all of his collaborators. And they went on to do this really extensive survey of 18 different specialties, urology, AUA was included, and 170 physicians per specialty. So they went to all these physicians, and it's a little different than the surveys that the RUC does nowadays, where you get an email, because back then I don't think there was a lot of email going on. So it was more, they would meet with these physicians. They would say, well, how long does it take you to do a circumcision? How long does it take you to do, a cystoscopy? How long does it take you? So they would go through all of this in an iterative process. And then they came up, this was the equation. So this is, for those of you with math buffs out there, Zoe, I think, yeah. This will be on your in-service, so just make sure you guys write this one down. No, just kidding. But this is the equation, if you're interested in health economics, that sort of basically, if you go back to this slide, this sort of puts it all into an equation format. All right, so up next, after Reagan, we have this president, George, you guys know George Bush, the first Bush, George H.W. Bush. Around 1989, there's this Omnibus Budget Reconciliation Act or OBRA, and bundled within this act, this law, this legislation was they're going to enact William Sow's alternative payment model, which is a payment schedule that's going to be based on the RBRVS, where you're going to look at relative physician work, practice expense. So what does it cost to run your practice? And then the third component that will be baked in is what we call PLI, or liability or malpractice insurance, which we all have to have malpractice insurance. So someone's got to pay for that. Does anybody know what this is? It's an omnibus. Yeah. So it's an omnibus. So that's what an omnibus looks like. But this was a piece of legislation, OBRA 89, where starting in, it kicked off in January 1st of 1992. There was this 5-year, they were going to sort of phase it in so that the system wasn't like shocked. So there'd be a 5-year transition starting January 1st. Components would be adjusted for the geography. So there's this geographic adjustment, knowing that things could be more expensive in New York City versus in South Dakota. So there's a GPCI based on geography. They wanted to eliminate specialty differentials for the same service. So if I perform a cystoscopy and a gynecologist performs a cystoscopy, it should be the same. Should be no different in RVU. And then the fourth component, which is very controversial in 2024, is this conversion factor that you might have heard of. This is something that has to get approved by Congress as part of updated legislation. And the conversion factor is sort of how you convert an RVU to an actual dollar. So we'll work through an example of that. And you can see how the conversion factor, when people say, well, where reimbursement is going down, it usually means because the conversion factor is going down. So that's been a sort of a thorn in physicians' side since really, as it hasn't increased since 1992. All right. So what's an RVU? So there's 3 components. So physician work is the first component, makes up 48% of the total RVU. So sometimes people will call it they'll put a little W there for work RVU. So that's the work that the physician is doing. And what encompasses that is the time for the procedure. So that's the skin-to-skin time. We also look at technical skill, judgment, mental and physical effort, and then the stress stress on the surgeon based on potential liability and harm to the patient. The second big component of an RVU is practice expense, because that makes up also for about 48% of the total RVU. And practice expense is when you're in the office seeing patients, so you're not in the operating room. That actually is a huge component of the RVU, because that's where you get paid for your clinical staff, so nurses, LPNs, medical supplies, so any supplies that are used for that service. And then it became fully resource-based in 2002. So all components of an RVU are now based on the resources used and not based on other factors. So this is how you can calculate an RVU to actual dollars. So this is for a 99213, which is a level 3 office visit. If you look here, and this is from 2018, I'll show you an update for 2024. So the work RVU was 0.97. The practice expense RVU was actually more than the work RVU, so 1.10. Professional liability insurance counts 0.07. So if you add that all up, you get to 2.14 RVUs. The conversion factor in 2018 was $35 and 0.9996. So we multiply that, so for a level 3 office visit, you'll get paid, your practice will get paid $77.04. That was in 2018. So that's sort of how that works. And you can do that for any CPT code or any RVU. So I've added this box here for 2024. So it's the same, this is the same from the last slide, the 99213. So for I think it was around 2001, all the E&M codes were re-reviewed by the RUC, and the RVUs actually went up for the E&M codes. So the RVU for 99213 is now up to, from 0.97, actually went up to 1.30. The practice expense also increased to 1.28. PLI increased slightly. So the total RVUs in 2024 for a level 3 office visit are now 2.68. You can see the conversion factor is now $32.74. So the only way to really increase physician reimbursement is by increasing the RVU, which rarely works. So the total dollars for a level 3 office visit has gone up by $10 from 2018 to 2024. But if you think about it, in the urology world, there were in CMS there were 2.25 million claims for a level 3 office visit, which amounts to $198 million in urology. So it's urologists do a lot of office visits, as you all know, and that just gives you sort of some overview of what the RVU to dollar figures look like. These are some, people are always curious, like what RVUs they get for certain procedures they perform. So I listed some of the more common ones that people may be curious for here. HoLEP 14.56, IPP gets you 10.44. This is an anterior posterior pelvic organ prolapse repair, 57260 is clocked in at 13.25. Robotic prostatectomy is 22.46. Lap nephrectomy, which would also be robotic nephrectomy, is 25.06. Heart-lung transplant will get you 91.78. So that just gives you sort of some. That's I think the highest RVU in the data set. So just some concluding thoughts on this middle section. You can sort of see how politics and health policy have really shaped the current landscape of physician reimbursement. Many presidents, even the Clinton administration, we didn't have time to get into what they did, and then certainly Obamacare have really shaped healthcare in this country. And we can learn from the history. There are things we can learn from so that we hopefully can make better choices in the future. And then I have a sort of, our RVU is the best currency of medicine. There's a lot of sort of swirling winds. Should we look more at quality of care and different outcome measures to sort of provide physician reimbursements? That's sort of for another day, but that's a question that's definitely been swirling around for some time. All right, so for the last 6 or 7 minutes, we're going to get into the RVU update committee. And this is Uncle Sam, sort of. So I'll sort of show you what you can do to help with this process. So the Relative Value Scale Update Committee was formed by the American Medical Association in 1991, right? They were integral in that OBRA legislation. They were actually part of that. So they knew it was coming in January of 92, but they wanted to still have a seat at the table, and they utilized their First Amendment rights really to petition the federal government. So it's an independent expert panel that provides recommendations to CMS, and CMS can do with that what they like, but we'll talk a little bit more about what they do with it. So this is the composition of the RUC. Really, it's meant to span the entire space of medicine, the entire house of medicine, really. And urology has had a seat at the table from day one, which is why I think urology has done fairly well in the landscape of reimbursement. There are 31 members, 28 of which are voting members. I'm one of the voting members of the RUC, and for a vote to pass requires a 2/3 majority vote. Individual members like myself have to be nominated by their specialty societies and then approved by the RUC. And RUC members, myself, when I'm at the table, I'm actually exercising my individual judgment, and we're not supposed to advocate for our own society. So if a urology code is being presented, I'm not able to speak while I'm at the table. That's for the AUA RUC advisors to do that. So this is our current team. we couldn't function without AUA staff. So this is Justice and Babica, our great AUA staff members. Jonathan Keekley is a urologist in Milwaukee area, and he did a fellowship with Chris Gonzalez, who was former chair of the Public Policy Council, and got him interested in health policy. So he's the AUA advisor to the RUC. And then Seth Cohen, who's at City of Hope, is the alternate advisor currently. Denise Asafu-Ajay, she was a Gallagher Scholar. And then Bill G. Sorry, Bill, we cut you off a little bit there, but Bill's been part of the process for a very long time and is a good man. Here's a picture of Dr. Asafu-Ajay, who attended as a Gallagher Scholar. We have the Gallagher Scholar come to one of the RUC meetings every year, and she was attending and has really been a great ambassador for health policy, and she's down at Loyola in Chicago area. I just want to pay homage to some of my mentors here. Norm Smith is retired, but he was a previous RUC member, got me involved and engaged when I was his fellow at the University of Chicago. Bill G., as I alluded to earlier, he recently retired. He's actually from the Milwaukee area, did his undergrad and med school here at the University of Wisconsin, and then practiced his career in Lexington, in private practice, Lexington, Kentucky, and he's a past president of the AUA. And then Tom Turk is a good friend, and he's the alternate, he's my alternate. So if I get sick or can't attend a meeting, then Tom takes over for me, and we work very closely together. He's also down at Loyola. We also have engagement with other membership. So we work closely with the AACU. So this is Terry Reagan, who's the AACU rep. So the AACU oftentimes attends the RUC meetings, and we work with them. Jyoti Chouhan, we have many observers. She's at Oregon, interested in health policy. She's a reconstructive urologist at University of Oregon, and has attended some of our meetings as observers. So if anyone's interested, we oftentimes can have one or two observers at one of our meetings. And what we do is the methods were pretty clearly laid out by William Sow in the 80s, and we follow a lot of that to this day, is that each CPT code, we look at the work, the practice expense, it gets compared to key reference services, expected use data, we look at that, and then any overlap with services that are performed on the same day. That's all critically analyzed. Ultimately, CMS makes the final call, but they do accept traditionally about 90% of the RUC recommendations. Not always. CMS then prices wages, equipment, and supplies. This is an example of the cysto pack. So every time you do an office cystoscopy, the practice expense, when you add up all these items, it equates to about $113. So not an insignificant amount of funds coming through that your practice to help keep the lights on, so to speak. The AUA work group works closely with the CPT team. And then the data that we get is primarily through member surveys. I know many of the faculty have been getting these surveys from the RUC. If you get one, please fill it out, because it's really important that we collect accurate data. From that survey data, we can then develop a strategic plan, and then the AUA will present those recommendations to the RUC. And so that's Jonathan Keekley and Seth Cohen. They'll make their presentations, they'll fight for urology, and there's 3 meetings a year that we attend. Now, the RUC's been embroiled in some controversy over the years. Everyone likes a good controversy, but the RUC, not so much. One of the jabs is that we're a secret society, that nobody knows what's going on, that it's, we're doing this behind closed doors. Well, we have to protect the RUC to some extent. We don't want people, there's no lobbying. We don't want lobbyists. We don't want industry to sort of necessarily get too much involved, because they have their separate agenda, right? So we try to, make sure that people that attend actually are there for the right reasons. That being said, all the recommendations, the voting, the minutes, they're publicly available. So here's a link to that. I should have put a QR code, and that's the in vogue thing to do, but But you can access all that after the meeting, so it's definitely not a secret society. We've talked about this a little bit at Grand Rounds about the RUC being sort of embroiled in this gender pay gap. And we know there's a gender pay gap, and I'm not here to say that there isn't. But there's been some publications over the years to say that the RUC was somehow responsible or partially responsible for that. Here's just a couple of the publications that pointed that out. Unfortunately, with these publications, they're comparing codes that are sort of apples to oranges. They're not apples to apples comparisons. They're looking at certain codes that have 0-day globals to 90-day globals, and it just doesn't make for a good comparison. So the AUA, actually myself, Tom Turk, and then we worked with John Hathaway and Mitch Schuster, who are gynecologists, ACOG. We worked together to actually look at it systematically, and we looked at 9 directly analogous code pairs of procedures that were formed in women that were analogous to procedures performed in men. And there really was no difference or systematic difference in work RVUs between the female and the male procedures. This is just an example of the procedures that we compared. So there are separate codes for a sling operation for male and a sling operation for stress incontinence that would be done in women. Work RVUs were pretty similar. And we did that for, these are 9 different code pairs, and there really was no statistical difference. Some of the female procedures had higher RVUs, some of the male procedures had higher RVUs, but it all kind of worked out in the end. So we did think that, we could explain the gender pay gap based on RVUs or the RUC. That was the conclusion. Does anybody know who this gentleman is? This is our last sort of pop quiz. I didn't think so, and that's okay. So this is Zeke Manuel. Does anybody know Rahm Manuel? That's his brother. Rahm Manuel was the former mayor of Chicago, chief of staff for Obama. And this is his brother, Zeke Manuel. And Zeke's been highly critical of the RUC. I think he makes some good points at times. He even calls the RUC unethical on a recent viewpoint that was published in JAMA, which I found interesting, being that JAMA is the official journal of the AMA. So, but it got published, and I don't think the 28 folks at the table are unethical. We have a strict code of ethics, but there's been some critiques saying that it's time for an update, time to look at different payment models, and we haven't found one really right now that's better, but perhaps we will in the future. And Zeke Manuel actually was part of the. He was an advisor to the White House when Obamacare was being developed, so he did help with that piece of legislation. So if you do get one of these emails from the AUA about a RUC survey, please fill it out. It'll help us to collect better data. Because here's an example of where we need better data. This was from in 2015, robotic prostatectomy code was created, 55866, and only 32 urologists completed the survey. And that was pretty abysmal when you look at the number of urologists that completed the survey. And on the survey, they said it took them 3 hours, skin to skin, to do the procedure. So they all were pretty fast. And then ultimately, the RUC recommended an RVU of 26.8. Well, CMS disagreed. The reason they disagreed was because the 180 minutes was the exact same as for the open retropubic prostatectomy. 180 minutes was the exact same, and the RVU for the open prostatectomy was 21.36. So they said, well, it's the same time as the open prostatectomy. Why should why should the RVU be any different? So they knocked it down to 21.36. The AUA went back to CMS and they appealed. They said, this is wrong. Like, we don't think this is right. And they actually presented there was this publication that just came out right after that in European Urology, where it was a huge cohort of 600 some thousand men that they had access to this hospital database, and they compared outcomes of open and robotic prostatectomy. And you could see in this huge cohort, the time was longer in the robotic prostatectomy. It actually was much longer than 180 minutes. So we took this data back to the CMS, and they bumped it back up. So this was a kind of a rare event of us being able to convince CMS that they made a mistake, and that was successful. So just to conclude, understanding the RUC process can help hopefully demystify the enigma. I believe the methodology is fair, ethical, balanced, and it's time tested. It's been really around for 30 years. There could be better systems coming forward in the future, which we're obviously open to. The AUA works very hard for fair evaluation of these CPT codes, and certainly if you get a survey, please try to fill it out. All right, so we talked about the role of urologists in health policy. I think we all have an obligatory role. We talked about how we all get paid. We talked about the RUC. Happy to take any questions, and thanks again for your attention to this matter. Origno, yeah. Yes, yeah. The GPCI is for the work, the practice expense, and the PLI, because liability insurance also is different in different regions. So yeah, it does get it. All three of the components of the RVU are adjusted for geography, GPCI. Yep. Dr.
Okay,
Risk.
that was great. I really enjoyed that talk. Thanks a lot. Two questions that are unrelated. One, just because I heard it from friends who we trained with that ended up in San Diego. Back in the early 90s, San Diego was considered rural, and they complained their reimbursement is still based on them being designated rural. How often is the geographical assessment redone? They claim it hasn't been redone.
Yeah, I mean, it's clearly San Diego's not rural. I've been there many times recently. I believe it's, I don't know the exact answer. I can try to find that out. I don't know how often the GPCI is updated.
Yeah.
But yeah, if it hasn't been updated since the 90s, that's a problem because the country has changed a lot since then, for sure.
Yeah. The other question was, was Zeke right? Because your argument there at the end where you had to prove to CMS about the time, that's not survey based, and you just showed a case where the survey maybe wasn't accurate because of low response rate, most likely. But
I think
you need other better data to guide this process.
Yeah, I think when you have response rates, the RUC considers a minimum response rate. It depends on how often the service is provided. So I think if it's over 100,000 claims, then you have to have 50 respondents to be considered adequate. If it's less than that, then 30 respondents is all you need. So if you're on the low end, 32, the data is going to be more skewed than if you get higher response rates. So that's why the response, it's still considered valid in the eyes of the RUC, because William Sow actually looked at, like, 30 is not some number he pulled out of a hat. They actually looked at the variance. Some really smart health economists looked at this, and they said, they didn't really see much difference between, if you had 30 respondents versus, 80 respondents. But I do think, you have to look at who responds, right? If you've got 30 respondents and they're all the fastest surgeons in the country, that doesn't necessarily help us. So, if you're filling out a RUC survey, you want to be honest with how long it takes you. Physicians, the other argument is that we're notoriously bad at estimating times. I'll be done in an hour, and then it's like 3 hours later, right? So I think that's the challenge when you're estimating. Could you get better data? Like, could you use, people have looked at like NSQIP data where they actually have the time marked. And it's actually pretty close to RUC estimated times. So I think where we're potentially heading is looking at more quality metrics for reimbursement, as opposed to this sort of So I think Zeke Manuel makes some good points, and I encourage you to read some of his papers. But I think the one where he was calling us unethical just was really out of line. Dr. Das.
Why is it safe stuff perfect? Like that it's like these big reason that
Why hasn't shifted towards that? I think the issue with some of the administrative data sets is it's not, participation in some of that is voluntary. It's not mandatory. So that may also skew the data, or it may lean towards academic centers and not some of the more rural or private practice centers. So the goal with the surveys is it's random. It's sent out to 5,000 AUA members at random. And hopefully we get a wide swath of the population so that you can account for, rural, urban, everybody hopefully will fill out some of the surveys so that we'll get that, some slow surgeons, some faster surgeons, and everything in between. Okay. Oh, Dan.
getting involved.
Yeah.
Thanks. You had your slide at the beginning about the time pressures for providers and trying to get the younger generation involved early. And arguably the younger generation, I mean, those who are just coming out of training, trying to get on their feet on solid ground with their practice set up and the time it takes to do that. You also showed, mentoring. I've forgotten the name of your advisor to the RUC, but he trained under Chris Gonzalez, so health policy. And you trained under Norm Smith, who was actively involved. So what's your advice for younger urologists who are, how to get them inspired and active, knowing that, volunteerism is a big thing. You don't have to tell us, but I'm assuming that EUA is not supplementing your salary with you're volunteering a lot of your time and energy for these efforts on behalf of all of us. What words of advice do you have for the younger generation to get involved?
I think I'm hopeful for that, because I think a lot of the next generation coming through is more sort of active in those types of issues, and for me, it's really it's the right thing to do, right? I think we have to be at the table, or else we're on the menu. Like, I really live and believe that, and I think getting involved in advocacy is a really good way for young folks to meet people all around the country. So I go back to sort of the mutual empathy and the high quality relationships. Like, I've met a lot of great people from all over the country in getting engaged and involved in this. I think when you go into practice, it can be very lonely and isolating. And this is an opportunity to really meet people and to get out there and to really you can really make a huge difference. It's a grassroots coalition type thing. So I think if you really want to do that and meet people and be involved and be engaged, we're always looking for good people to do that. So I think that's sort of my take home is when you start practice, yeah, you got a lot of stuff to do at home to sort of take care of your practice. But I think you also, like I said, it can feel very lonely and isolating when you're doing that, because you go from being in a big group of residency and fellowship to now, it's, practice is a bit more isolating. It's you, it's your nurse, it's your MA, but by getting engaged in advocacy and policy, it opens up a lot of, windows for you. So something to consider. All right. Thanks, everybody.